Welcome, everyone. I am Dr. Anupam, Professor of Medicine at Santosh Medical College. We will be doing a clinical reasoning simulation session titled The Red Flag Embolus today. As you can see on the screen, we are exploring a high stakes diagnostic race. We will follow the case of a 64-year-old truck driver who presents with sudden vision loss, an ataxic gait, and splinter hemorrhages. Notice the subtitle pointing out the key challenge: identifying the red flag in a multi-system presentation involving both ischemia and eosinophilia. We will navigate this complex clinical scenario using a simulated multi-agent approach, featuring insights from a resident, an attending, and an expert large language model. All these discussions will be moderated by human in loop who provides case inputs and the necessary guardrails. Let us dive into what we aim to achieve today. Looking at the two columns on this screen, you will find our core learning objectives divided into clinical reasoning and advanced diagnostics. On the left side, our goals are to differentiate between systemic embolic syndromes, specifically cholesterol embolization versus hypereosinophilic syndrome. We also need to interpret multisystem ischemia when extreme eosinophilia is present and recognize the true significance of splinter hemorrhages. Moving to the right column, we will tackle advanced diagnostics. You will learn to avoid the common trap of a preserved ejection fraction in eosinophilic cardiac disease. Finally, we will analyze the critical role of an endomyocardial biopsy in solving systemic diagnostic dilemmas. Let us look at how we will structure this interactive case study. On this slide, the methodology and perspectives for our multi-agent simulation are laid out. As you can see in the dark blue box on the left, we will use an interactive data release process spread across 4 distinct rounds. This allows for real-time interpretation by our simulated resident, consultant, and expert models. Notice the green box on the right, detailing the different perspectives. The resident will establish the initial clinical priorities. The consultant will then provide a critique of the plan using Bayesian refinement to update our probabilities. Finally, the expert will step in to identify the key pivot, which is the crucial piece of data that changes our entire diagnostic trajectory.
Now we are ready to meet our patient and review the initial data.
Here we have the clinical context and initial labs for our 64-year-old truck driver. Looking at the blue panel, the patient presents with a resolved episode of sudden blurred vision, a frontal headache, encephalopathy, and an ataxic gait. His history is highly relevant, showing hypertension, chronic kidney disease, and an aortic aneurysm repair 7 years ago. Now shift your attention to the red flag labs on the right. His total leukocyte count is 10,300 with 59% eosinophilia, giving an absolute eosinophil count of 6,000. His creatinine is elevated at 2.5 milligrams per deciliter. Physical examination reveals splinter hemorrhages in his hands and feet, and his chest X-ray shows bilateral apical opacities. Let us pause for a moment to consider what these clues might mean. Notice the large question across the top of the screen, asking for your leading suspicion. We have 3 distinct prompts to guide your thinking. First, consider the combination of an aortic history, splinter hemorrhages, acute kidney injury, and eosinophilia.
Does this specific cluster point toward cholesterol embolization syndrome?
Second, look at the sudden, although resolved, vision loss. You must ask yourself how this fits into a broader vascular framework. Finally, the third box highlights the 59% eosinophilia. Does an absolute count this high suggest a simple allergic reaction, or should we be worrying about a primary bone marrow process? Keep these questions in mind as we see how our simulated medical team approaches the exact same data. On this screen, we see the initial hypothesis generated by our 3 clinical agents. Starting on the left, the resident places cholesterol embolization syndrome as the top priority at 50%, largely due to the prior aortic aneurysm repair. They also consider eosinophilic granulomatosis with polyangiitis at 25% because of the lung findings. In the middle column, the consultant agrees with prioritizing cholesterol embolization, but pushes for actionable next steps, specifically ordering an urgent brain MRI and a fundoscopy to look for Hollenhorst plaques. On the far right, the expert identifies the key pivot. They note that severe eosinophilia in the setting of an embolic syndrome should immediately raise suspicion for cholesterol embolization. Let us move forward to see what the neurological, and cardiac workups reveal. We now have advanced imaging and electrophysiology results displayed on the screen. Looking at the dark blue box on the left, the diffusion-weighted MRI shows multiple recent strokes scattered across both cerebral hemispheres, the pons, and the cerebellum. This widespread distribution strongly suggests a proximal central embolic source rather than isolated vessel disease. Now, direct your attention to the brown box on the right, detailing the electrocardiogram findings. While the patient is in normal sinus rhythm, there is ST segment depression and biphasic T waves in leads V3 through V6. Crucially, there is also low voltage in the limb leads, which raises the suspicion of an infiltrative process in the myocardium. We must now synthesize these new neurocardiac clues to locate the exact origin of the problem. Notice the primary question highlighted in the blue banner. Where is the embolus coming from? Below it, 3 critical questions challenge our current diagnostic framework. First, think about the low voltage seen on the ECG. Does this specific finding change your view of the heart's involvement, perhaps shifting focus away from the aorta? Next, consider the multi-territory embolic strokes we just saw on the MRI. You must weigh whether the aorta or the heart is the more likely culprit for showering emboli so widely. Lastly, the bottom box asks why the encephalopathy resolved so quickly, which is an unusual feature for massive structural brain damage. Let us reveal how our clinical agents adjust their reasoning based on these new imaging findings. Looking at the updated reasoning on this slide, you can see a major diagnostic shift. On the left, the resident has moved away from cholesterol embolization and now favors hypereosinophilic syndrome with Loeffler endocarditis at 45%. The multifocal strokes convince them that a central proximal source is responsible. In the center, the consultant demands an urgent transthoracic or transesophageal echocardiogram with contrast to actively hunt for an apical thrombus, while also monitoring troponin levels. The expert on the right solidifies this pivot. They explain that the combination of an MRI-confirmed embolic shower, extreme eosinophilia, and subtle ECG clues points definitely toward a cardiac source over an aortic one. The next logical step is to look directly at the heart. Here we have the echocardiographic confirmation and the latest biomarkers. As you can see in the blue section on the left, the transthoracic echocardiogram reveals normal left ventricular systolic function. However, it also uncovers a large mobile sessile mass attached to the basal septal wall of the left ventricle. This is our smoking gun or the embolic shower. Now look at the biomarker panel on the right. Troponin I is significantly elevated at 3.90 nanograms per milliliter, and CKMB is 24 nanograms per milliliter, confirming active myocardial injury. Additionally, the erythrocyte sedimentation rate is drastically high at 106 millimeters per hour, indicating profound systemic inflammation. We need to pause and interpret what a mass in a structurally normal pumping heart actually represents. Read the prompt in the large blue box. A mass in a heart with a normal ejection fraction. What does this mean? Below, 3 key clinical dilemmas are presented. First, considering the basal septal location, we must decide if this mass is a thrombus or a primary cardiac tumor like a myxoma. Second, you have to ask yourself if a normal ejection fraction completely rules out severe eosinophilic heart disease. Often, we equate heart damage with reduced pumping function, but that might be a dangerous assumption here. Finally, look at the last question regarding treatment. With multiple recent brain infarcts, is it actually safe to start systemic anticoagulation right now? Let us see how the clinical agents unify these disparate pieces of evidence. On this slide, our agents unify the clinical picture. The resident shown on the left is now 70% confident in hypereosinophilic syndrome with Loeffler endocarditis, concluding the ventricular mass is a mural thrombus. The consultant in the middle agrees, but pushes for a cardiac MRI for better tissue characterization. Crucially, they recommend starting high-dose prednisone at 1 milligram per kilogram immediately, provided underlying infections are ruled out. Notice the experts teaching pearl on the far right. They emphasize that in hypereosinophilic syndrome, severe cardiac disease can present entirely as an embolic stroke, even when the ejection fraction remains perfectly preserved. To confirm this diagnosis definitively, we must obtain direct tissue evidence from the patient. This screen displays the definitive tissue verdict. that solves our diagnostic race. Look at the endomyocardial biopsy results on the left. The pathology shows clear evidence of myocardial inflammation, featuring a prominent infiltration packed with eosinophils and lymphocytes. This directly confirms eosinophilic myocarditis. Now, shift your focus to the clonality testing on the right. The bone marrow is normocellular without any clonal abnormalities. Furthermore, the genetic testing for the FIP1L11 PDGF are alpha mutation returned negative. Because we have end organ damage without a specific genetic or reactive cause, the final category is classified as idiopathic hypereosinophilic syndrome. With the diagnosis locked in, we must now consider the most appropriate long-term management strategy for this patient. Notice the main question on the screen asking how you would manage this patient long-term. The 3 white boxes below highlight the specific therapeutic decisions we now face. First, you must weigh steroids versus imatinib and understand exactly why the negative mutation status we just saw dictates this choice. Second, given the massive embolic strokes and the ventricular thrombus, you need to determine the optimal duration for systemic anticoagulation. Finally, the third box prompts you to consider the risk of recurrence once the initial steroid taper begins. Managing this condition requires balancing aggressive immunosuppression with the prevention of further embolic events. Let us review the final consensus from our simulated medical team. Looking at the final reasoning on this slide, all 3 agents are fully aligned on the management plan. On the left, the resident confirms that with idiopathic hypereosinophilic syndrome established, high-dose steroids and therapeutic anticoagulation are absolutely mandatory. The consultant in the center outlines the exact regimen, reiterating the start of prednisone at 1 milligram per kilogram. They also add a crucial monitoring step, which is to watch for the resolution of the left ventricular mass using serial echocardiograms. The expert on the right highlights the final clinical pivot. They note that the combination of biopsy-proven eosinophilic myocarditis followed by a dramatic response to targeted treatment validates the entire diagnostic journey. We can now look at the overall outcome of this fascinating case. As you can see in the large text box on this slide, we have reached our final diagnosis. The patient suffered from idiopathic hypereosinophilic syndrome presenting with Loeffler's endomyocarditis, a massive left ventricular mural thrombus, and a devastating systemic embolic shower causing strokes and splinter hemorrhages. Below the diagnosis, notice the highly positive patient outcome. Following the administration of high-dose prednisone and systemic anticoagulation, there was a rapid resolution of the cardiac mass. Additionally, the patient's peripheral eosinophil count completely normalized. This underscores the importance of rapid diagnostic pivoting when faced with multi-system disease. Let us visualize how our thought process evolved from the initial presentation to this successful resolution. This flowchart beautifully visualizes the diagnostic evolution across our 4 rounds. Starting on the far left at round 1, the combination of an aortic history, eosinophilia, and splinter hemorrhages initially drove a strong suspicion for cholesterol embolization syndrome. Following the arrow to round 2, the discovery of multiteratory MRI strokes and low voltage on the ECG forced a critical pivot away from the aorta and toward the heart. Moving to round 3, finding the left ventricular mass alongside elevated cardiac biomarkers solidified the suspicion of Loeffler endocarditis. Finally, the arrow leads to round 4, where the endomyocardial biopsy provided the ultimate confirmation of eosinophilic myocarditis. Let us extract the most critical lessons to apply to your future clinical practice. Looking at the final pearls on this screen, we can distill this complex case into actionable clinical logic. In the left column, remember that in hypereosinophilic syndrome, severe cardiac disease often presents as a mural thrombus well before any overt signs of heart failure appear. Do not fall into the trap of a preserved ejection fraction, as it absolutely does not exclude life-threatening endomyocardial injury. On the right side, the diagnostic logic dictates that whenever you see extreme eosinophilia in the setting of an embolic syndrome, you must immediately check the heart and think far beyond a simple allergic reaction. Finally, always remember that an endomyocardial biopsy remains the absolute gold standard for conferring a Loeffler's diagnosis. Let these principles guide your approach to multi-system embolic diseases.